I'm Xiuning Li. I'm one of the thoracic medical oncologists here at MD Anderson in the thoracic medical department. So I'm associate professor, also serving as a deputy section chief. Let's start talking about the SOHO studies. Now we have SOHO-01 and SOHO-02 in the non-small cell lung cancer. So the idea is HER2 mutation, although only 3% in non-small cell lung cancer, but we know it's a targetable, actionable mutation. We start to develop small molecules to help with the patient in this setting. SOHO-01 is the first study to evaluate a new medication called Bayer-88 in HER2 mutation non-small cell lung cancer. Initially, we started with dose escalation and dose expansion. Based on the SOHO-01 data, we really observed the fantastic treatment efficacy with a response rate can be as high as in the 70s for patients who had prior treatment without the prior anti-HER2 target treatment. So now we're expanding the data into patients who have prior HER2 treatment. We also just reported this year at ASCO for patients who never received treatment, HER2 metastatic non-small cell lung cancer. Across multiple cohort, we've seen very consistent response, very high response, and we're looking forward to see the duration of response and progression-free survival. I believe we'll talk again in the future meetings. Moving forward, because of the really impressive efficacy and unmet need for this patient population, we started a randomized global phase 3 study. That's the SOHO-02 we're talking about. So the SOHO-02 will enroll treatment-naive HER2 mutation non-small cell lung cancer patients and randomize all the patients to either Bayer-88, now have a name called savolitinib, versus chemoimmunotherapy. That's the current standard of care globally. So we look forward to enroll patients from all continents, essentially, and then testing if the HER2 targeted therapy can be superior to what we're using now. HER2, the molecule belongs to a family of ERBB family, and then the ERBB1 is actually EGFR. That's very commonly seen mutated in lung cancer, and we have fantastic treatment options. The backbone for EGFR patients is targeted therapy, oral medication, small molecule. It gives patients years and years of benefit. So HER2 is ERBB2. As you can imagine, those two molecules share a lot of commonality. We call that homology. So for HER2, when it's mutated in lung cancer, that also drives proliferation, happens in around 3% of all lung cancer patients. The unmet need for HER2 really is, as of now, as of we're talking in the summer of 2025, we still don't have an oral medication, small molecule that's approved for this patient population. I'm actually very glad to say that the Bayer-88 or the savolitinib is not the only one that's trying to improve the situation. We have seen zangertinib have very good efficacy. Prior, we have older TKI trying to go into the space to help patients. So I think 2025 to early 2026 will be a fantastic year that for HER2 mutation non-small cell lung cancer population that we might see really exciting approvals. Currently, we actually have one targeted therapy for HER2 mutation lung cancer patients. That's trastuzumab deruxtecan, which is antibody drug conjugate. It's IV medication. It works really well for this patient population. What I want to highlight is we need a different type of drugs. We call that different mechanism of action, MOA, so that the patient can have many options over the journey of their disease progression. And then because of different mechanism of action, we can perceivably seeing they're combined or they're combined with other drugs. So I'm looking forward to see more drugs coming through different mechanism of action and then prolong the patient's life as much as we can.